presentation. Okay. All right. So here's my outline for today. We're going to do a little bit of definitions. Then we're going to talk about data. We'll go on to social determinants of health, some thoughts around personalized medicine, thinking about the micro versus the macro, and then we'll leave room for questions and discussion. And then I would love your feedback. I always want to get better at this, at giving presentations, at conveying information and context. So I'd love to hear from you how I did. So whenever we have conversations about issues of social determinants of health and race and ethnicity, I think in the United States, our education system and society have left us poorly equipped to have these conversations in a meaningful way, because we don't have shared definitions and shared concepts for a lot of these. And so I like to start off with just having some basic definitions. I'm not going to read you my definitions, but I thought I'd just give a moment to allow for everybody to sort of get a sense of, when I say social determinants of health, what do I mean when I say race, ethnicity, when I say racism, discrimination, disparity, and inequity. This is what I'm talking about. All right, and again, I'll make copies of my slides available, so you can also have these. I have citations here as well for where these definitions come from. So why does this matter? Well, we think about historically, the U.S. Census is sort of one of our oldest institutions for measuring measuring race and ethnicity, and ranging from the first census in 1790 all the way to actually 2020. This is a slide that's actually created by the Census Bureau that looks at all of the various different categories and how they've evolved over time. From basically 3 categories back in 1790 all the way to much more comprehensive and detailed structured in the 2020 census. And these are just the official categories. The census has allowed for other and write-ins for a very long time, and it's also had a number of discussions about introducing new classifications, new demographic categories over time. And I think that we can expect some additional changes for the 2030 census. But for those of us in healthcare, perhaps even more relevant than the census is thinking about sort of federal reporting guidelines, right? Because of the way that healthcare and research are financed, these end up being some of the important ones. And the very first guidelines came from Directive number 15 in 1977 that had 4 categories for race: American Indian or Alaska Native, Asian or Pacific Islander, Black, White, and Hispanic origin as an option for ethnicity. That was updated in 1997 by the office, by OMB, the Office of Management Budgets. The big change there was the breaking up of the Asian or Pacific Islander category into 2 new reporting categories: Asian and Native Hawaiian or Pacific Islander. And then the 2010 census and the new Office of Minority Health, starting in 2014, recommendations for new roll-up categories to provide even further granularity on almost every single one of these categories. So again, helping us understand a little bit better about who people are and how do they identify, what are their identities. And so this matters to us in healthcare because the EHR, that place where we work, where we do all of our documentation and billing and chart review and order entry, is at the end of the day a reporting tool where that helps us capture all of this information, all this demographic information. And to the extent that EHRs are required to follow certain guidelines, primarily from ONCIT in the federal government, they follow certain standards for data collection. Now, there's a lot of variability, and each institution can implement those data collection practices in a number of different ways. But at the end of the day, it is the process of collecting that data that's a lot of where this starts. So when we think about race and ethnicity data in the healthcare information pipeline, I like to break it down into, there's sort of these four structures, right? So you have social systems. So this is the conversations that we are all having all the time, right? These are social constructs of race and ethnicity. It's and how those interact with and influence and are influenced by individual level identity and affinity. These are things that are dynamically interacting. There's considerations for intersectionality and acculturation, identity and belonging, right? That's what's happening at the level of both people and society. But then when people interact with healthcare systems, that gets captured, right? And so that's what happens much lower. And what I tried to represent here is this funnel, right? That first level is broad and expansive. But when we turn that broad and expansiveness into data, we immediately start narrowing. And so the first place is that capture, that healthcare encounter with some kind of demographic data collection. Maybe it's the patient registration, maybe it's a hospitalization, maybe it's a research survey. Whatever it is, there's a point there, and there's a lot of factors that go into that. The collection method, was it self-report versus a staff member made a choice on behalf of the patient? Is there trust between the provider and the patient? Is there comprehension? Did we actually accurately get across what is the information we are trying to capture and why it matters? Then you start getting to some of the technical issues, right? So what is the EHR interface and data model? So what are the data entry systems? Are the race and ethnicity fields, are they free text? Are they single select? Are they multiple select? Are they separate? Are they the same? And a lot of this comes down to, how is the EHR implemented? Do you have certain standards and policies and regulations that govern the process of data collection? Is there transcription error? Did you, an example from my own institution, we had in 2015, we were running a data cleaning exercise and found a surprisingly large number of patients whose primary language was listed as Estonian. LA is a very diverse community. A hub for an Estonian diaspora, we are not. And so I was very concerned. And after doing a little bit of digging, we realized that in the drop-down menu where patients get to choose their primary language, there's most of the languages are listed in that native language. So Spanish is listed as Español, and that language after Español is Estonian. And so what we think happens is, somebody who's entering the data just basically hit the down key one too many times, hit enter, didn't bother to check, moved on. So again, these transcription errors, these interfaces are critical to capturing this type of information. The third layer is a little bit more complex. It's ETLs, are extract, transform, and load processes. Basically how we take the data from the EHR and put it into a research environment. And depending on how those concepts are mapped, they may or may not introduce additional problems. Then finally, there's actual research data product creation. So this is the activity that many of you are already engaging in. You might be reaching out to your CTSA or to your IS department, or maybe you have a data and informatics department, and you're asking, I need, for this list of 100 MRNs, I need their race, ethnicity, age, zip code, etc. And in the process of creating that data product, there may be problems, or there may be inconsistencies. Finally, then there's cleaning and recoding. So that's when you get your data set and you realize, oh goodness, that the EHR allows for free text race, and so instead of having 5 OMB categories or 14 OMH categories, I have 150 different versions of different race categories. I, as a researcher, now have to figure out some meaningful way to group those. And that cleaning and recoding process can introduce a lot of bias and error because we don't really have standard approaches on how we do that. And finally, I keep saying finally, next, statistical analysis, right? So you might be you might realize that your patient populations are too small because you're really interested in looking at the experience of, say, South Asians or Filipinos or Central Americans, but it turns out that you don't have enough individuals in these groups. And so for your statistical analysis, you might end up collapsing, well, we're just going to say it's going to be white versus black versus other. Or you might have a, or you'll say like, patients of color. And so in the statistical analysis, you lose even more granularity. And then finally, it's that publication and federal reporting, which many of us are required to do either by NIH or by various agencies, is that, until fairly recently, NIH only, they wanted all their data in the 5 OMB categories. And so even if you had preserved that granularity, it all had to get collapsed at some point. Different publications, different journals might have different preferences in how it's done. So there's a lot of opportunity to lose detail and to introduce bias into this process. And I'll give you a perfect example of what I mean by this. And so this is some unpublished data that's in preparation for a manuscript. And so I just give you that caveat, saying that this is not publicly available yet, but I wanted to share it with you all. This is data from the National COVID Cohort Collaborative, which is a very large collaboration across over 100 medical centers in the United States who are sharing near real-time EHR data about patients with COVID. And so it's kind of an amazing feat that was stood up relatively fast in response to the pandemic to create this data source that can be used to better understand the outcomes of patients with COVID. And so, one of the things that we were interested in looking at was, well, this is a perfect lab to look at what do the EHR race and ethnicity data of patients look like from across the country, because it's a pretty representative sample of at least academic medical centers from around the US. And what you are seeing here is when we think about those main OMB race categories, how they break down. And so you see obviously that the single largest group are people who identify as white. The second largest race group in America is non-conforming, which tells you something about the way that we collect data in the United States and how that data may or may not represent the people in the US. You can see on the inside, the use of the color pink sort of gives you a sense of what proportion of each group is Hispanic or Latino, with one of the largest being in that non-conforming group. Over 51% of Latinos fell into that non-conforming group. And so we can talk a little bit more about actionable to team members at the institution. Do we integrate them into the EHR? Do we bring them into our intranet? Do we just do a lot of awareness campaigns? How do we then match a specific resource to a specific patient? Do you have a rules-based system? Do you do sort of take a clinical decision support approach? Do you use fancy natural language processing and artificial intelligence? And then it's how do we connect a specific patient to a specific resource? Right? Do we, hand that patient a flyer? We email them information, we text them, we mail it to them. Do we contact that resource on behalf of the patient? Doing a warm handoff? Do we have electronic referral systems? And then how do we follow up and measure impact? Do we have a way to do that? Do we follow up directly with a patient or with the resource or data sharing? So this is a very complicated, and we're just beginning to scratch the surface of how this is done in a data-driven way. And so all of this, so we've talked about race and ethnicity, we've talked about data provenance, we've talked about social determinants of health, about how we capture it, how do we use it, and so why? And so when we think about personalized medicine, and I'm using the term personalized medicine non-specifically. Some people use precision medicine. I'm referring to the general concept of tailoring treatment to individual patients, and the overall prevailing thought that tailoring is done at the genetic level. And so that's whereas I think based on what we know about social determinants of health and the huge role that they play in health outcomes, that maybe, just maybe, we should be thinking about that tailoring happening at the macro level around the social determinants of health. And so again, thinking about COVID-19 as a use case, you have two diagrams here on the left. And the micro is thinking about, great, the host genetics. Does the host express this specific gene? Well, then what are the epigenetic and methylation processes? The transcriptome and allostatic regulation. Well, then there's host virus interaction, host immune response, host behavioral response, which then drives medical interventions or access to medical interventions. That tells us about their access to healthcare and healthcare systems. But the social determinants of health really have a role to influence all the way down this scale from micro to macro. Same thing if you think about the evolution of the disease, right? If we think about sort of COVID-19 infection as a stepwise process, you have your baseline health status, you have exposure risk factors, you have infection risk factors. Once you get infected, you have disease severity risk factors, transmission to others, and then an outcome, right? And very broadly speaking, the outcomes can be, you can either recover, you can develop PASC, post-acute sequelae of COVID, or you can have death. And sure, there are genomic factors at many of these different stages, but social determinants of health have what we would call a multi-collinearity with those genetic factors, right? So they occur at every single one of these stages, and they have a significant influence at any one of these stages. So if you were to personalize a person's treatment based on the expression of some specific gene, why wouldn't you also do it based on their conditions in which they live, grow, work, and age? So why does all this matter to an informaticist like me? And I really love this so the Children's Health Fund released this report called the Persistent Healthcare Access Gap for Children in Poverty. And I will read it to you because I like it that much. It says, however, if not developed and implemented equitably, technology advancements could actually widen disparities in care as the haves get more and the have-nots are increasingly left behind. And this is 2015, way before the phrase digital divide was coined. And so I think it was really prescient, and they were early on, as I'd like to think that a lot of pediatrics is. But it's really true, and we're seeing it play out today. This is a perfect example of how this happens in the real world. This is a great paper by Obermeyer et al. It was published in Science in 2019 called Dissecting Racial Bias and Algorithm Used to Manage the Health Population. And basically, what this research team did is that they looked at a care management algorithm, right, that used by a very, very, very large insurer in the United States. So millions of humans have this algorithm applied to them every day. And the algorithm basically decides which patients should have access to this additional sort of care management program where they have individualized social workers and care managers that really help them connect to healthcare. And what they found is that there was a big difference among who got referred to the program based on race. So they found that Black patients were much less likely to be referred into the program than white patients, and that the Black patients who made it into the program were much sicker than the white patients' counterparts. And as they started to take apart the model and try to understand why this was happening, because an algorithm is not capable of racism. An algorithm is simply applying a series of logical steps that has been taught to it. And so it is either reflecting a flawed data set that it was trained on, or a flawed understanding of a healthcare system, or three, it's just bad. That's a different conversation, but let's just assume that you have good algorithms. And in this case, it was the second case. So it was not understanding the system, right? The social determinants of health. So what they found out is that one of the things that the algorithm was weighing very heavily was, well, if a patient has a lot of outpatient subspecialty visits, they must be sicker. And therefore it gave a higher score and referred the patient to the program. Now, those of you who are healthcare providers immediately caught the red flag without me telling you anything else. Well, not just because you have more outpatient subspecialty visits doesn't mean you're sicker. Many patients don't have access to subspecialty services, whether it's because it's not covered by their insurance or because of transportation barriers or copay barriers or any number of barriers, or bias in the system of not referring. There's plenty of research that shows that patients from several under-resourced communities are less likely to be referred to specialty care. So it's that it's that disconnect between understanding how the systems actually work, right? If the algorithm were looking at, say, ICD-10 codes and hospital utilization and ED utilization and other measures of complexity other than just the number of outpatient visits, then it would have been much better. And sure enough, what you see here in the second graph is this is the original scoring metric for patients who were in the data set who were labeled as Black. They made those very same changes that I just described. And this is what actually should have happened, right? So the referral of patients who are Black into the program would have matched almost exactly that of the other patients in the data set. So this is an example of the algorithm sort of failing because of the way it was programmed that did not take into consideration social determinants of health and how our systems drive the data that is available to be analyzed. This is another one that has been in the news over the last 2 years, again, in the light of COVID. So many of you probably saw this, right? Pulse oximetry may be inaccurate in patients with darker skin. Senator Warren, Booker, and Wyden urged the FDA to address concerns about pulse oximetry. There was this, correspondence that has been, even though it's only a year old, has been cited like 150 times. In New England Journal of Medicine. The basic story is that the way that pulse ox are designed and the way that the algorithms that are trained to analyze the changes in the light don't take into account skin pigmentation. And so at lower levels of saturation, the more pigmented a patient's skin is, the less accurate the saturation is, meaning that a patient might show a more normal saturation level than they're actually experiencing. It varies by brand and algorithm. Most of them found that the issue happened at much lower ranges, sort of under 80%, under 70%, but still significant inaccuracies. Now, you'll notice these two other clippings here at the bottom is that we've actually known this since 2005, right? There are early papers that told us we knew this was a problem in 2005. And we did nothing as a society, as an industry, until all of a sudden we all started caring, or saying that we cared. But I find this a very telling example of dissemination of knowledge and even just the bias that we have within healthcare, within the healthcare industry, and the interaction between providers, regulators, and government and industry. When we knew this, we knew in 2005, and it took COVID-19 for Congress to care, for the FDA to care, for us to care, right? These are our colleagues. These are physicians publishing in medical journals, and we as a community didn't care. And so I wanted to bring this home with diabetes. So why diabetes? So my own work is in diabetes. I work a lot in diabetes devices and diabetes device data integration. And diabetes is, to me, as fascinating as it is, this highly quantifiable disease, right? Everything about the way that we monitor it, the way we treat it, is quantifiable in very granular ways. We have a number of devices, CGMs, AIDs, smart pens. We have validated patient-reported outcomes on mobile apps, wearables, and the world of technologies that are going to become available to us over the next decade or so are going to be So exciting. But diabetes is also a disease that is exquisitely sensitive to social factors, to socioeconomic factors, to racism, to bias, to healthcare access. And so as we think about the work that we need to do to deliver better personalized care to our patients, we have to do better. And we have to take into consideration all of these issues of how we source the data, how we collect it, how we clean it, how we process it, and then how do we use it in meaningful and ethical ways to actually do what it's meant to do, which is to enable people to live their best life and achieve their best health. So just some closing thoughts for you all. That I hope I was able to convey is that one is that data quality matters, and that context matters, not for people and their data. There's still a lot of work that we need to do to build and improve the infrastructure that we have in place, whether it's in our EHR or in our research systems, to meaningfully capture social determinants of health. And we have to be really thoughtful about the ways in which we use that data. But I do still firmly believe that data and technology are incredibly powerful tools that can be leveraged to improve outcomes and reduce the health gaps that are faced by under-resourced communities everywhere here in the US and all over the world. So with that, thank you so much for your time. Thank you for the invitation. If you can, please feel free to use these links or this QR code. I'd love to get your feedback and hear what you thought. I will stop sharing my screen, and then we can hopefully have some questions.
Thanks very much, Juan, for that lecture. It's really eye-opening. And in terms of all the different biases, from intrinsic biases from the algorithm, how we collect the data, how we care for patients. In the diabetes space, how do you envision we could reach a better delivery of care with more equity and when we think about patients with diabetes, and how do you think we can and this is just bringing a little bit the idea of WOM, of how the study that you're leading with them, and as a disclosure, I'm an advisor, but really Juan is leading a study in WOM to integrate all this different parts of the ecosystem of the diabetes data, including the use of wearable CGM into the health system, and the use of dashboards and extracting the data, and kind of understanding at the individual level how to care for each of those patients. So how can you tell us a little bit about that model on how is it?
Yeah, happy to. So for context, we're running a 3-phase study in Guam, the island of Guam, which is a U.S. territory, focused on diabetes. And in phase 1, we're doing sort of retrospective. So we're working with a number of ecosystem partners, hospitals, insurers, public health department, to aggregate data around people with diabetes, to start developing some predictive models, some machine learning models, to really understand, what are the factors locally in Guam that impact how people's disease evolves. In phase 2, we'll be doing more of a prospective study, right? So we'll be actually recruiting individual patients and following them longitudinally, and using wearable devices and CGMs to, again, create this more comprehensive data profile of the patient, and combining that with their claims data and their health records data. And in phase 3, we'll be testing out some interventions to actually, what can we do if we can predict that a patient is going to have a potentially worse outcome? Great, cool work, get a nice paper, but what can we do about it? How do we prevent that outcome? And my guess is that it's going to be what we do is going to be all really low tech stuff, because the reality, healthcare, I can we could talk, AI and machine learning and data integration, ETL pipelines all day long. Healthcare happens at the level of people, and connecting those people to the resources they need and empowering them to meaningfully have agency in their own health and in how they access the resources that they need for their healthcare. And it happens at that level. Obviously, it happens at the higher level, which is how do we change the systems that actually support humans and that enable people to access these resources. And so we have to do both. And so I think it's going to be, it's going to be really low tech stuff. It's going to be like the promotora model, right? Like helping people, like, great, there are resources in your neighborhood. How can I help you connect you to those resources? Like, do you need a car? Do you need me to deliver it to your house? Is it not in the right language? Is it not at the right level? How can I best support you in achieving your best health? And I think all of this data but those systems can be expensive, they can be resource intensive, they require humans, they require contact. And so I think the value of the data is letting us know who should we be reaching out to first, and how do we create resources for people who maybe they don't need that human, they just need better insight into what's possible. And so can we, it can help us sort of create this pyramid, right? Like, not all patients need the same thing. Some patients, they really need you to go on that journey with them, and some patients need a little bit of information to make better choices. And we all live in that spectrum in life, whether it's professionally or personally, right? Like, sometimes we need handholding, and sometimes we just need a little bit of information to make better choices. And the goal of the data is to help us understand who is who, and how do we provide those resources appropriately to the people who need it at the right time.
Awesome. I don't know if Mo had a question or Ambar. You feel free to jump in.
So, Dr. Espinoza, this was a great talk. I wanted to ask you about the social determinants of health screening piece, because one I wanted to know is when patients, from all different backgrounds, they come in primary care, and we are already giving them like 3-4 referrals when they have diabetes. Go to your ophthalmologist, go to your podiatrist, and then we hand them with 5 more referrals, from this SODH screening. Does it actually help to improve outcomes? And 2, are we kind of overwhelming the patient with all the screening that we are doing with little change that we can actually make to their lives? So just wanted to get your thoughts on that.
Yeah, so it's a great question, right? Because it's especially, certainly in my world of pediatrics, a lot of it we're dealing with is new diagnosis. Although in adults, with type 2, you're also dealing with new diagnoses. And yeah, we overwhelm patients all the time. So yes, we overwhelm patients, and yes, we still need to do it. And I think that's where the sort of the implementation science researchers and the behavioral researchers have a huge role to play, which is like, how do we do this? Because maybe, so one of my colleagues, Jennifer Raymond, who's the chair of endocrinology at Children's, she's developed this really, I love it, a very brilliant sort of approach of like, what, we can't possibly talk about everything that diabetes does in a 15-minute visit, 20-minute visit, an hour visit. We just can't. And so what her clinic does is that they basically have, in addition to your individual medical visit, they do these group visits. And in the group visits, they just break it down, right? Like, in Q1 of this year, we're going to talk about food. And in Q2 of this year, we're going to talk about medicine and insurance. And in Q3 of this year, and they just sort of, they're like, we can't talk about it at all. You're not going to absorb it. We can't get all the information. Like, it's not going to work. And so they pace it out. And I think those kinds of models where we think about, here's the library. I'm going to give you the keys to the library. I'm going to walk you through the library once every couple of months, and we're going to focus on a specific part of the library. And I think potentially that model, I think, has promise in terms of how we help patients navigate the deluge of information that's available to them. Does social determinants of health screening help? We haven't been doing it in clinical settings at scale meaningfully to know, what the impact is, say, like in health systems. We know from research that yes, that those screening efforts and those prioritization of patients based on their needs does in fact lead to better outcomes. And certainly one of the things that a lot of our bosses care about is better utilization of resources, right? Like you can decrease ED visits, you can decrease hospitalizations by driving patients, and therefore, improve, financial performance by triaging patients appropriately based on their social needs.
Terrific. Thank you so much.
Yeah.
There was a question from Mo. He had to run, but his question was about solutions to race ethnicity entry error problems. What are the solutions? So both to sort out the data we have now and how we collect better data in the future.
Oh man, that's a great question. If I knew the answer to that. Well, I'll tell you what we're doing. One is so there's a couple of different. One is just training our own selves, our teams, our physicians, our staff, that it matters and why it matters, right? It's not just a required field in the registration. Like it matters because we make decisions about it. Right. Well, we need to have insights about our patients, about our community that we serve. And this data point is important in how we do that. So one is like, we just need to care more about it. Two is that we need to use systems that eliminate error. Right. Like, free text as a default is terrible. And then we have to have a really good understanding of what matters to, if the insights that we're going to make are based on, let's say OMB categories, right? And so that's pretty standard. People are familiar with that, right? Then we need to have data collection systems that enable you to collapse to OMB categories. Now that doesn't mean that you should only ask people, well, you get to choose one race and it's one of these 5. Because that's crazy, because we as individuals don't identify that way, right? Like I've been filling out other for my entire adult life because I don't identify as any of the 5 federal government race categories because I'm from Venezuela. I was born there. I grew up there. I'm not white. I'm not Black. I'm not Asian or Pacific Islander. My identity as Hispanic is my only identity. I don't have some other identity. So there's a balance that we have to achieve between allowing people to identify that this is who you are. You get to tell us who you are, and then being able to map those concepts of who people are to the hierarchically higher level concepts of, well, this is the information that we can act on. And in some ways, it's a technical problem of mapping and rollups, right? If anybody does work with ICD-10, you're sort of familiar with like the rollup problem. Like, well, does this code really mean the same thing as this upper higher code? But the other is just it's in the way that we do it, right? Is empowering people to tell us who they are, to identify however they want, right? Like that is them, and that is their right to do so. How do we then take that information and use it meaningfully? And so it's a 2-pronged problem. At least in the research side, we've been working on developing some standardized frameworks for how to do the recoding, right? So look, the EHR data was captured how it was captured, right? In 2014. So like, there's nothing you're going to do about it today. But what can we do about how do we recode that data when we're going to do an analysis? We're going to, statistically, so that we're trying to preserve as much granularity as possible. So, not a great solution, but I hopefully it steps in the right direction.
Absolutely, that's one of the tougher ones, I'm guessing, and I think also maybe standardizing the degrees of how those social determinants of health can affect people at different dimensions, because it's the yes or no is also a little bit limited, I think. So I think you can have more issues compared to other people, like the degree of the exposures you have had.
Yeah. There's a sort of like this. There's an in semantic analysis we call it an ascertainment problem, right? Like, is it enough to know that it's present? Yes, no, or do you need to know to what degree? Do you need to know, like, how much information do you need to know? And that's tough because sometimes we know. So, for example, if your interest was you were developing models to predict patients who are going to have better or worse outcomes after metabolic surgery. So you're going to do, gastric sleeves or Roux-en-Y bypasses. The existence of food insecurity at any degree is predictive of poor outcome. So you don't need the granularity, like, well, in the last 6 months, in the last 12 months, or like, well, do you live in a food desert versus a food swamp? Like, doesn't matter. Food insecurity, yes, no, great. That's a problem. We need to address that problem. But for other things, the things around housing instability, like that the degree might matter. So yeah, it's sort of when we collect the data, it's the reason is, well, why are we collecting the data? Why does this matter, and what's it going to tell you? And then ask the right level of granularity, and that's hard because we don't know for a lot of things.
But I don't know if anyone else has any other questions. We're around the hour, a little bit past, but before you leave, if there's no questions, I have another one since I have you here. Sure. One is, for example, is specific for the diabetes space when we're thinking about social determinants of health and access. It's so difficult. So patients, underserved patients, are more likely to discontinue wearables or less likely to be prescribed, or have worse outcomes and worse glycemic control. So there's a lot of disadvantages there. So I don't know, have you guys thought about, we're trying to use, for example, access has been always an issue. So they're less likely to be offered technology, CGM, because we assume that they will not be able to get it, or because they have Medicaid or Medicare, and we don't want to go through the process of doing that because it's a nightmare and doesn't never happen. So there's some solutions. For example, you probably are familiar with Parachute. We're trying to use that to try to navigate all the barriers that are there. But I'm wondering if you guys are doing anything in LA using technology to try to identify high risk patients and how to serve them better.
Yeah, it's a tricky question. So, I know for example, in our research studies, not in our clinical practice, one of the things that we do is we ask about sort of their just overall access to technology, right? So what are they currently using? Do they use mobile phones? Do they use apps? Do they have tablets? Do they have other wearables? Maybe just they personally have a Fitbit, to give us a sense of where they are and what is their level of their ability to access internet, say, at home. Because a lot of these technologies, if you don't have a regular access to Wi-Fi, you're basically just downloading at clinic visits, and then it's no different than it was 10 years ago or 15 years ago. So what we've done in some of our research studies is that as part of the onboarding process is we then connect them to what's called here in LA, like the Lifeline program, right? Sometimes referred to as like the Obama phones, but it's the idea of great, like you need, just in life, you need a phone and internet access, right? Because phone and internet access are critical to engage in society today. And so we help patients solve that barrier. And now all of a sudden we've improved their ability to participate in our research study. So our research coordinators actually take that on. And that's, we're lucky and well-funded, and we have research coordinators who can do that. You then have to make a use case for your clinical and operational teams to do that. But yeah, I mean, I think you touched on a couple of different things. And so one is, the recommendations, part of it is standardizing care, and standardizing care is hard. Physicians don't want to be told how to practice. But so one component of it is, look, if patient, here's a level of criteria, every patient with criteria should be offered a CGM, and then we can deal with how we get them the CGM and how we, and how we connect them and make sure they have the resources to use it and to understand it. But in some ways, standardization is really helpful. And that's one great thing that you can use algorithms for, right? You can say, every patient who has been on insulin for 12 months and has a hemoglobin A1C worse than 8 and has had 2, 3, or fewer visits in the last 12 months, candidate for CGM. I'm just making things up. I'm not actually an endocrinologist.
That makes a lot of sense.
Right, but that is a simple algorithm that every EHR can run. It can generate a patient list. So like here's 12 patients this month that need to be called about a CGM, or that the next time that they show up at clinic, you need to discuss CGMs. And then it's the investing in the organizational structures, right? Because then it does become, inevitably, Francisco, you might experience this, but my patient panel in LA is overwhelmingly Latino, right? Because they want a Spanish-speaking doctor who can speak to Spanish-speaking parents, and they don't want to deal with interpreters, and so patients sort of self-refer and self-select into my clinic, and so all of a sudden now, as a physician, I have an extra burden compared to other providers because I have to do all of this extra work for my families who have limited English proficiency, and the organization isn't supporting me, but I have a disproportionate share of that extra work burden that you're describing. And so, I think we as our institutions need to take on that burden and do that for our, to support our not just our providers, but really to support the patients, right? Like we're supporting the providers so that we can support the patients. But yeah, having those mechanisms where like there's a member of our staff whose job it is to deal with Medicaid and Medicare and getting the CGM, like we have a workflow for that. But yeah, standardization, I keep going back to implementation science. If anyone here is an implementation science person, please help. You guys are so important.
Absolutely. We have several implementation scientists around. So I think we need to still keep doing some work about that. There have been a couple of publications on how to help reducing the burden of Medicare requirements for the use of technology, for example. Just basic things for the people that really need it, for example, patients with type 1. We all should have access to the technology. Still having issues. But I think I'm going to end here, Juan. We could keep you forever. And we really appreciate the time. That was an awesome lecture in a different perspective of the big picture of how to use these terminologies and the importance of addressing social determinants of health and with a big picture level. So really appreciate your time, and hopefully we'll have you again soon in the near future.
Perfect. Well, thank you so much, everybody, for having me. I appreciate all the questions. If again, and please, if you have a moment, I would love to hear your feedback on how I can do my job better. Thanks, everybody.
Thanks, Juan. Appreciate it.